tried to see uh, when you taper steroids, what is the risk of patients developing a flare? And they saw that the slower you completely take it off, so for someone who's maybe like 2.5 mg per day, instead of directly stopping it, if you make it like 2.5 mg every, you miss every 2.5 mg every 3 days first, then you maybe give it a gap of 1 day in between for a couple of months, and then you stop, then the chances of flare happening is low. But in general, if you're less than 5 mg, don't worry. I mean,
So as Rudra said, now you have to strike a balance.
yeah.
And where the balance is struck, that is the most important. We want to strike a balance at zero, but it's not possible in everybody.
Yeah.
That is what we want. But it's not the physician's wish. It is both patient and physician together make a decision that is 2.5 milligram making you so happy that you don't want to come down below that. So that is how it works. Okay, we have this girl who was Shivangi who had sent her first question. She has had she's been started on mycophenolate from 23rd May. And after that, she has developed these rashes which are there on her face, body, everywhere. And she's never had a skin rash in her lupus, 20 years of lupus, except a malar rash in the beginning. So, and some of them are like urticaria. So she is asking that can mycophenolate ever cause this? Any drug can cause a drug reaction, any drug. So if you have been started on a new drug and you are getting a generalized rash, which is itchy and which also has that kind of a urticarial rash, then you first stop the drug and see it. It could be because of even steroids can sometimes cause rash. While we use steroids for treatment of drug rash, but they can also cause. So I would suggest if you have started on a new drug, please stop the drug, wait for 10 days, and then see how it goes.
Yeah, definitely.
And can you see some other question? Then there is a question from Madhu Sharma. So
Yeah,
Rudra,
yeah.
if you can take that she's been on mycophenolate 2 grams and she is having amenorrhea, no periods for 3 months. And her obstetrician is saying it is because of the
Yeah.
MMF.
So Madhu, so the thing is ki if you have been started on mycophenolate recently, it means probably you have had some serious manifestation of lupus. So it might be affecting you in a serious way, kidneys or something like that, for which it has been started. So in general, mycophenolate or any of the drugs we use for lupus, other than cyclophosphamide, do not have an effect on periods. What happens is if your body is going through any stress, and lupus flares are a source of great stress to the body, your cycles may skip. This is for any sickness, anytime you're sick in any way or any period of severe stress, you might have a few skipped periods. This is something we see very commonly in our patients when they have a major flare of lupus uh, for 3 to 6 months, sometimes even 9 months. They do not have their regular cycles, but once the disease is under control, the body has its own mechanisms of bringing back to your normal schedule. So generally you'll start having your cycles after 3 to 6 in 3 to 6 months. It takes a different time for everyone, but it is most likely not mycophenolate that is causing you to miss periods. It's most likely that your disease was very active, your body was under a lot of stress, and that's why you missed your periods in between.
The other reason could be that if you've been had a recent relapse and you are on started on mycophenolate, if you're on high dose steroids, because
Yeah.
steroids are hormones, so they can affect your cycles. So if you are taking, we don't know how much of corticosteroid or prednisolone you are on. If you are on a dose more than half milligram per kg, then your periods definitely you can have oligomenorrhea or
Yeah.
lack of periods for a few months. So that is other thing. And third thing, never forget pregnancy. Always check do your pregnancy test because sometimes it can happen and you don't come to know about it. So always do your urine pregnancy test and exclude pregnancy. So these three things must be done. And if you have severe anemia, because when you have severe anemia, that time body tries to save the blood. So they also that can also cause you lack of periods for few months. So check that your hemoglobin is okay. You're not on a high dose steroids and you don't have a very severe disease, as Dr. Rudra said, that any serious disease can cause you lack of periods. Okay, Nisha, you have been raising your hand for a long time. Can you unmute yourself?
Sadi, how long we can take technos? How long? It's been
Tacrolimus.
5 years. Yeah, it's been 5 years I'm taking. So how long? And
Tacrolimus.
how much safer side? Yeah, for the class 4 and
Yeah.
So
So
recently there is a study which has come from Japan, because tacrolimus was started from Japan, predominantly from Southeast Asia, because it wasn't initially tried for lupus nephritis in the Western world. It all came from, I mean, our side, Southeast Asia, Japan, China, and all. And just, I think, last month or this month, the study has come 10 years. So they have followed up patients whom they have maintained on tacrolimus for 10 years. And they have shown
okay,
that it doesn't do much harm. But there is a other viewpoint that because they have not done repeat kidney biopsies, and we know that tacrolimus can have some side effects on the kidney, as has been seen in patients who undergo transplant and other things. So they say that there may be a thing that after a few years you should try to reduce it and substitute with something. But the Japanese believe that it's a wonderful drug. So we have also had
okay,
patients who are on tacrolimus for 5 to 7 years because they just didn't respond to anything else, not to cyclophosphamide, not to mycophenolate, not to rituximab, and they had only response to tacrolimus. So those patients are taking very low dose. Like some of our patients are only on 1 milligram, 0.5 milligram twice a day. We generally gradually come down on the dose from 4 milligram to 3 milligram to 2 milligram and try to have the minimum dose. But they are so fine on just 1 milligram, so you don't want to stop it, and their kidney function is all normal. They don't have any side effects. So this study is very reassuring that at least 10-year data is now available that it does not cause too much harm.
and one good
okay,
thing
okay.
about
Thank you, ma'am.
tacrolimus is you stop it and in 12 hours it goes away completely. It has a
Yeah,
very short time inside your body. So if you
yeah,
miss one dose, tacrolimus levels in your body go down to zero in 12 hours. So if
I
by
never
chance
guess.
you develop some problem, it is very easy to take you off tacrolimus.
yeah.
So
Okay,
Yeah, thank
okay,
you.
thank you.
Ma'am, for how long
Yes,
period does the MMF should be used after being remission?
yes.
If patient
Rudra, you
is
want
in
to?
yeah,
remission,
so
for how long
so
should the MMF should be used?
Yeah, so
Okay.
so generally for lupus nephritis, so when you have disease in your kidneys, MMF we will give you at a dose of 4 tablets per day, that is 2000 mg per day for at least 12 to 18 months. After that, so we generally try to come down. We try to come down to 2 tablets a day, that is 100,000 mg per day. How long you stay on 1000 mg per day is a very tricky question. It will again differ from patient to patient. We will try to at least give a consolidation period of at least 3 years, 4 years of overall treatment for lupus nephritis. Again, there was a study recently that showed the slower you come off. So there are two factors that affect uh, how good you stay when you're tapering off MMF. One is how slowly you taper the background drug, that is MMF or any other drug. So someone who is stopping it very suddenly, drastically, is more likely to get a flare of the disease again, rather than someone who is slowly tapering it off. So what we'll do is after maybe 12 to 18 months, we'll make it 3 tablets a day from 4 tablets a day. Then for 6 months, we'll keep it at that dose. Then we'll maybe make it just 2 tablets a day, morning, evening, for another 6 months to 1 year. And after that, even if you're still in remission on that, we'll generally come down to maybe 1 tablet a day and then stop. But overall, for at least 3 to 4 years, we do like to treat with MMF. The other thing in that study, what came out is depends on whether you are on steroids or not. So they saw that patients who have first successfully tapered and stopped steroids, it is best if after they're able to stop steroids, you try and stop mycophenolate. But that is not possible for everyone. But in general, the period of time would be 3 to 4 years, and that some of you might need to stay on maybe just 1 tablet twice a day for longer periods of time. I mean, whatever keeps you well, that is the key thing.
And this is when you don't have any relapse in between.
Yeah.
That is 3 to 5 years. If you have a relapse in between, then your clock starts again. So that is the problem. So patients who have multiple relapses, generally you don't want to stop the drug because you don't want the kidney to, because every relapse means some part of the kidney is going off. So
Okay.
patients who have very good response in the first time when they get lupus nephritis, you try to make a attempt at 3 years, 3.5 years to stop it and see. But if they have a relapse, next time you will wait for 5 to 6 years before you make an attempt to stop it. If the patient has another relapse, you probably would never stop it. You will continue
Mm.
with 250 milligram twice a day or 500 milligram twice a day because you don't want to have a relapse. Even
Okay.
though despite taking that much drug, they can have relapse. But we hope that the relapse will be less. So in that hope, if you can get them off steroids is better, as what Dr. Rudra said, that it is better to come off steroid rather than to think that I should be off MMF.
MMF. Oh,
So because MMF has hardly any side effects at a dose of 1 gram. And if you are taking it morning, evening, it's not very difficult to take. You can take it in the morning when you go for work, before that, empty stomach. And when you come back at 6 p.m. or 7 p.m., you can take it. So it's an easy drug
okay.
to take. And now the cost has also come down in our subcontinent. Previously, it was very expensive and our patients could not afford, but now it's much cheaper because of the the generic drugs. So patients can take 2 tablets, and that really works quite good if patient cannot tolerate azoran. The second question is patients who are poor, who cannot afford mycophenolate. A switch from MMF to azoran can be done, but it should not be tried very early, because what people have shown is that if you try it before 2 years, the chance of relapse is higher. If you do it after 2 years of mycophenolate therapy, the chance of relapse is much less. And you are successfully able to change from mycophenolate to azathioprine, which is a much cheaper drug for patients to take in our settings.
Okay, ma'am. My doctors has done the same, ma'am. My they have stopped they have stopped the prednisolone steroids very early. Then they continued my MMF. It's been 8 years. I've been taking only MMF.
Yeah, yeah,
Steroids has been stopped very early, and
yeah.
they continued MMF only 250 mg dose
And I was saying
twice a day.
250 BD, some patients do very well on 250 BD. I just give that
And I'm
much.
doing well from that also.
Yeah,
And
yeah.
it's been
So
8 years, there is no relapse.
So the patient, actually, you have a dialogue with the patient. After 5 years, do you want to stop it? Half of the patients will say, I don't want to stop it. I'm happy
Mhm.
taking this 250. My disease is fine. Why do I need to take even a 5% chance that my disease will come back?
Mm.
So it is a dialogue between the patient and the physician. Then you can decide what you want to do. Some patients are don't want to take drugs. They will say, no, no, let's try and stop it. If it comes back, I will restart. So it's a
Okay.
different patient. Every patient is different. But
Okay,
after
ma'am.
5 years, you can definitely think of tapering it down slowly. So we have one new message. Somebody had asked on cyclophosphamide. Okay, this is one. My
Okay.
muscle twist. Nilima is asking my muscle twist more than 5 times per day since 15 days. And I am diagnosed 2 months ago.
Okay. So, I mean, so you're probably talking of something called as fasciculations. So you can feel some muscle twitching somewhere in the body. Most commonly, it happens in the thighs, calf, or your arm muscles, the large muscles. There are many causes for it. So the most common causes are actually electrolyte imbalances. You know, the muscles, they respond to, they need a lot of metals, potassium, calcium, things like that, magnesium, these three mainly. So if you are having, you know, especially in this heat, it is very common. You lose lots of electrolytes through sweating and through water loss. So it's actually quite common in the summer months where there is a lot of heat. So first thing I would say is stay hydrated, take lots of electrolytes, take electrol or ORS, fresh fruits, mangoes, oranges, things like that that have electrolytes, and just wait it out. I mean, muscle twitching mostly it is benign. So there is an entire disease entity called benign fasciculation syndrome. There are these people who will have muscle twitching throughout life with no cause and no long-term harm. So just patience is the key there. No, but especially in the summer months, you should always be aware that you are getting enough electrolytes.
Other thing which can happen is because you have been diagnosed 2 months ago, if you're taking high dose steroids, sometimes it can cause low calcium. So if
Yeah.
you're having like this, your hand is becoming like this, and like you have technique like features. So look at your calcium also. I mean, are you taking adequate amount of calcium supplementation or not? Because we don't know what muscle twist you are having. You're written muscle twist. So if it is twisting like this, then have a look at it.
Ma'am, cyclophosphamide or mycophenolate mofetil, which one drug is better in organ involvement lupus? Mostly we have seen that those who patient have used the cyclophosphamide, it has more side effects than mycophenolate. Which one is better, ma'am, for initial flare up of lupus?
Both are good. Each one has its own advantage and disadvantage. The advantage of cyclophosphamide is that it is our last resort. So we use it in very serious conditions where we can't take risk. Mycophenolate is an oral drug. There is no intravenous preparation available. So when you give orally, you are not 100% sure how much is going inside. People measure mycophenolate levels abroad, but in our country, they are not very easily available. And absorption can be very, very variable in different patients. So wherever it is a life-threatening thing, we always would like to use cyclophosphamide because those patients are in ICU or they are very sick. In those patients, nobody takes chance and gives mycophenolate at that time. Then question comes patients who are moderately sick, where you can use either cyclophosphamide or mycophenolate. In those patients, the choice lies with the patient. The advantage of mycophenolate is it's an oral drug. Patient doesn't need to come to hospital for infusion. It is safe. The risk of infection is little less with mycophenolate as compared to cyclophosphamide, but the cost is more. The pill burden is high. You have to take 4 tablets a day. In contrast, cyclophosphamide is a very cheap drug, 200 rupees, and it is, you know that the patient is taking it because you are giving it. Compliance is 100%. Then the patient comes to you. The only problems are, one, increased risk of infection as compared to mycophenolate. Second is you need to be in the hospital in daycare for about 2 hours or so. But there are people who are using oral cyclophosphamide pulse also in poor countries, and they have shown that it is almost as good or little less than IV cyclophosphamide. So it depends from patient to patient, what patient wants, what is the condition of the patients. But abroad nowadays, IV cyclophosphamide use has become only limited to life-threatening conditions. So there they would like to use mycophenolate because the risk on infertility, that was one there abroad because their patients are much older. Our patients are much younger. I mean, their most lupus occurs at around 30, 25, 30, that way. So their risk of infertility is higher and they generally don't have early marriage. Our people, by the time they get lupus, they have already had 1 or 2 kids. So they are also not too much worried about infertility, even if they have it. So it's a balance of everything: cost, convenience, side effects, everything put together, you make a decision. But efficacy wise, both are equally effective. Both are equally effective. Risk of infection is little less with mycophenolate.
And ma'am, what about rituximab? Nowadays, most of the doctors are using rituximab here in Nepal too.
How much safer is this for using that medicine?
Yudra, you want to take it?
Yeah, so rituximab alone cannot be given for lupus except for very few manifestations like muscle weakness or for arthritis. You can give rituximab alone, but for any major organ disease like kidney disease or neuropsychiatric lupus, you have to give it with MMF. So if you're giving it with MMF, the chances of infection do increase manyfold. I mean, effectively, you are wiping out your immune system for a good period of 2 to 3 months. Uh, we still do we use it for people who are not responding to anything else, but we use it again as a last resort when you are not on MMF, you are not having a response, or on cyclophosphamide and MMF, you have not had a response, then we will generally add on rituximab. Infection risk definitely is more in South Asian countries. That is a major problem with rituximab. It is otherwise a very good drug, but infection risk is more. Uh, maybe abroad they are not having as much issues, but we are having issues. I mean, we have lots of patients coming back, getting admitted. Even though it's more convenient, you have to take a dose every 6 months. But an infection when you have gotten rituximab is much more difficult to handle. So we use it sparingly. We use it only when you absolutely need it. Uh,
Like some of the rare manifestation, like sometimes severe thrombocytopenia, low platelet count, that is good
yeah.
for that. So, or some kind of a rare neurological manifestation where it is useful. So those patients get only rituximab. But
Yeah.
otherwise, as what Dr. Rudra is saying, we are not using too much of rituximab. We are still very careful in using it.
Even AIH, if you're
Yeah.
having autoimmune hemolytic anemia,
Yeah.
rituximab is now coming into first line. But those are very
Good.
specific conditions where we are using.
Shanta, you had a question. Yes, Shanta. Can you unmute yourself? Shanta, can you put on your mic?
Shanta,
Shanta Podal.
Shanta Di,
She have a question she was asking in the beginning also.
Hello, namaste everyone. So what I wanted to ask is like I am her daughter, Santa Baudil's daughter, and I wanted to ask if like what medicines to take. Like she has herpes in her head, and so what medicines to take?
Yeah, I'm sorry, Shanta, I was not clear. You said she had herpes on
she
her
has
leg?
herpes.
Okay, okay. Uh, and did it develop on medicine or
She is on medicine.
okay? So in general, herpes reactivation is quite common in those who are above the age of 60. It can happen if you have ever had chickenpox or any herpes virus infection in childhood. When your immune system goes down, normal population above 60, you're at risk of herpes reactivation. But when you're getting immunosuppressants, especially like things like rituximab, like mycophenolate, like cyclophosphamide, you have definitely more chances of herpes virus reactivation. And the problem with herpes virus reactivation is it is very painful. So shingles, it is called shingles. It is painful and it leaves generally a permanent rash in a lot of people. Uh, so, I mean, the problem is you can't really permanently stop medications if you have lupus, right? For preventing herpes. What we do is we will stop your lupus medications for like 2 weeks. And in that time, we'll give you antiviral like acyclovir for generally 1 to 2 weeks. And what acyclovir does is it will reduce the severity and the duration of the attack. The attack will still go on, but it will reduce the duration and severity of attack. And sometimes people have something called post-herpetic neuralgia. That is the nerve in which the herpes virus stays. Generally, that nerve, in the distribution of that nerve, you have a lot of pain in the skin. So for that, your doctor may prescribe you something like a pregabalin or a carbamazepine medication like that brings down the pain. But that is temporary. You can take that for 2 weeks to a month, and then maybe you can stop that. And after 2 weeks, we will generally put you back on your lupus drugs. Uh, we now have a vaccine for shingles reactivation. It's called Shingrix, but it is an expensive vaccine. I think the complete course of Shingrix right now in India costs above 10,000 rupees. So maybe with time that cost will come down, and then it would be great if any patient on any immunosuppression gets the vaccine, provided the cost comes down. But till then, these are the things that we do generally.
Oh yes, thank you, doctor. So like her doctor has given her valacyclovir and
Yeah.
not her lupus medicine. So is it okay?
Yeah. Valcyclovir, acyclovir are the same type of drug. So generally, you will be on it for 1 to 2 weeks, and then if you are on some lupus medication, you will be put back on the lupus medication.
So, like, basically, we don't need to stop her lupus medication, right?
So we will stop for around 1 to 2 weeks till the herpes goes away. Because otherwise, if you take the lupus medications at hydroxychloroquine, you can continue. Low dose prednisolone, you can continue, but we will stop a patient who is taking, say, mycophenolate, azoran, azathioprine, or cyclophosphamide, any of those drugs. We will generally stop for 1 to 2 weeks till the rash goes away completely. Otherwise, if you are taking mycophenolate, azoran, or these medications during herpes reactivation, there is a very minimal risk of it, spreading all over the body, spreading systemically. So generally, we will avoid, other than hydroxychloroquine and prednisolone, we'll avoid the other drugs for 1 to 2 weeks.
What about Pangraph, doctor?
What about? I'm sorry.
Pangraph.
Pangraph is tacrolimus.
Okay, tacrolimus. Again, the same applies
Yeah.
for tacrolimus, like
Tacrolimus
mycophenolate.
also. Best to
Yeah.
stop it for about 2 weeks.
For about 2 weeks, you should stop.
Yeah.
Thank you, doctor.
Okay. Are there any more questions or is that all?
Mudita has a question, I think, on the chat. Immunosuppressions. So immunosuppressions can effectively manage lupus, but it increases the risk of infections and other side effects. So that is a very valid point. But we have to always strike a balance between what is going to control your lupus and what is going to give you side effects. Preventing infections is very basic common sense. Things that your parents tell you from childhood: wash your hands, eat clean food, not go into crowded places, drink clean water. Those are the things that you need to do to prevent infections. And just one thing that I wanted to point out, some vaccinations I feel are essential for, especially because lupus is a disease that affects females a lot. And India, South Asia, we have a lot of prevalence of cervical cancer. So now at least the Indian national program is coming up with cervical cancer vaccination against human papillomavirus. And anyone at least in the 15 to 25-year age group, I think, should be taking that vaccine from the government program when it becomes available. So that is one thing that absolutely should be done. So
Yeah, so then there is another question on person who has class 3 nephritis, high cholesterol 3 weeks ago. I'm taking atorvastatin. So this high cholesterol could be because you have lupus nephritis, you must be having proteinuria, and sometimes the cholesterol levels can be high. So I don't know if you really need to take, well, if they have given you, depends on what your levels were. And you are also on a high dose prednisolone, so that also changes your lipid profile. So generally, we wait for some time before we give these medicines for cholesterol. So once your disease will get better, maybe your cholesterol values will come down. And if you are overweight, try to reduce your weight. And if you are taking steroids, please don't eat too much so that you don't gain too much weight, because you're on a 50 milligram prednisolone. So that will cause your appetite to increase and you will keep on eating and gaining weight, which will also further increase your cholesterol and other issues. So you need to take balanced diet, not increase weight, do simple exercise, and check your cholesterol. And then, depending on that, it's not that once they've given you atorvastatin, you will have to continue taking it lifelong. It's not like that. Once your disease gets better, maybe your cholesterol levels will also come back to near normal values. And the rest of the medicines we have already discussed: hydroxychloroquine, lifelong; mycophenolate, 3 to 5 years minimum; prednisolone, gradually taper down to the minimum possible dose. So that is what we will do. Fatty liver can be a serious concern with lupus nephritis. No, fatty liver is because of obesity. It's nothing to do with lupus nephritis. It is corticosteroids, lack of activity, increased weight gain, people who have diabetes. So they are the ones who get fatty liver. I am 80 kg, she's writing. Okay. My appetite is increasing day by day. That's what I said, that your appetite will increase so much. So you need to cut down on that. Take salad. Just eat kheera, kakadi, your this one, watermelon. If you have radish. So every morning make a salad bowl and keep it in your fridge. Whenever you feel hungry, just eat that. Don't eat any of the rest of the stuff. And otherwise, you have the rice puffs, which are very good, which are available in our places. So if you feel hungry, take rice puffs. And if you feel more hungry, take another glass of water. So you try not to eat, because if you keep on eating, then your cholesterol will not come down. So we have to do
Another,
that.
there is another question.
Okay, there's somebody who has got joint pains. That you have to show to your physician, that is it a disease relapse or is it something else?
Yeah.
Because yeah, your face and leg is swelling after taking medicine because you're on 50 milligram prednisolone. So it will cause you this swelling. So your doctor will reduce your medicine. It's only 3 weeks, no? So they will reduce your medicine. As Dr. Rudra had said in beginning, that now we are reducing steroids much faster.
So, I mean, don't stop your medicine on your own. These
Yeah.
are temporary, It will go away after a couple of months when they start coming down on the steroid dose. Definitely.
And he has given you less dose. Your 80 kg has only given you 50 milligrams. So that shows that he is only using nearly half milligram per kg. So, but you need to keep your balance. Don't increase further your weight. Okay, I think Dr. Babita, I think we have done now.
Yeah.
Or anything
Yeah,
more is
okay.
left?
Some of the Sajna Sherpa has written, my face and leg is swelling after taking medicine.
Yeah, that is because of steroids. That's a
Yeah.
steroid side effect. She's taking 50 milligram.
Anyone? कसैको अरू क्वेसन छ कसैको फ्रम नेपाल? पूजा?
Whenever I
Preeti?
hold something, 3 of my fingers goes numb.
Deepa?
So, I mean, so
दिपाको
this is
क्वेसन
very
छ?
difficult to answer. We will need to examine before,
Or
commenting on
Will
fingers
answer.
becoming numb. It can be multiple issues. So it's best if you can show it to someone, go to your doctor and show him. Yeah. So Shanta, Dr. Amita and I, we are both at SGPGI Lucknow. So I mean, it might be too far for you, but it's up to you. We both of us are in the same hospital, SGPGI.
Please tell
so
about.
vaccine is for lupus patients. Lupus patients should take the regular vaccines. And as what Dr. Rudra said, that HPV vaccination, which is to prevent carcinoma of the cervix.
Yeah.
So that it should be taken by young girls. Best to take at that time. And there is also people give influenza vaccine every year, especially people who have more serious illnesses and who are on severe immunosuppressive drugs, or who are going to take immunosuppressive drugs for long periods of time. So they are at increased risk of infections and flu. So people also try pneumococcal vaccine, but how much is it beneficial, we don't know as yet, but it is recommended to be given.
Then Sajna has asked, can lupus nephritis patient can do any type of exercise?
Yes,
Yes,
yes. If they
yes.
are fine, they can do everything. Somebody is writing, I'm sleep deprived. Most of us are sleep deprived. But some people can get insomnia. That is there. Insomnia can occur because of high dose steroid. Insomnia can be a feature of lupus also. Insomnia can occur because of anxiety. It can occur because of depression. So you have to find out the reason. You have to go and see a doctor and find out the reason why you are getting less sleep.
So, Sajna Sherpa, she asks which food to avoid. I mean, there's no particular one food to avoid. Healthy, balanced diet that you're taking all your life, you should take that. If you have nephritis, just avoid lots of salt, at least for the initial 6 months. Don't add any extra salt to your diet. Avoid like papad and achar and things like that have added salt. just avoid those things for the initial 6 to 8 months. That is fine. Otherwise, you can eat anything and everything you have been eating from childhood. Quantity should be less, not quality should not go down. That is the important message about food.
I think questions are finished.
Yeah. So nice talking to you all. Nice talking to everyone from Nepal. Hopefully we can have this kind of a thing again.
Yeah.
Thank you everyone for joining,
Thank
and
you.
I hope you got something out of it. And we
Yeah,
hope you all
many,
stay well
many.
and
This
take your drugs and be happy.
Uh,
Most important is happiness.
yeah, ma'am.
Yeah.
Thank you so much, ma'am.
Thank
Thank you
you.
so much.
Thank you
Dr.
so much, ma'am.
Thank you so
And
much.
Dr. Rudrarpan. It
Mm.
was really very informative. Even for me, I learned a lot from this meet. Thank you very much, ma'am and sir.
Thank you.
Thank
Okay.
you.
Okay, we can end the meeting.